5 surgeries, 5 procedures that are performed every single day in hospitals across this country, 5 operations that are described to patients as routine, safe, and low risk. And I would not allow a single one of them to be performed on anyone in my family over the age of 60 without an extremely serious, extremely detailed conversation first. Now, before I tell you why, let me tell you who I am and why you should listen to what I'm about to say. My name is Dr. Michael Kent. I have been a practicing physician for over 20 years, and the majority of my career has been spent working exclusively with patients over the age of 60. I have sat across from thousands of seniors who came to me after a surgical procedure they were told was safe, and who were dealing with complications their surgeon had never properly prepared them for. I have read the research, I have seen the outcomes, and I believe that every person over 60 has the absolute right to know what that research actually says before they agree to go under the knife. Please subscribe my YouTube channel now. Let us go through all 5. Surgery number 1 is spinal fusion. Spinal fusion is one of the most commonly performed back surgeries in the United States, particularly in patients over 60 who are dealing with chronic back pain, spinal stenosis, or degenerative disc disease. The surgery involves permanently joining 2 or more vertebrae together using bone grafts, rods, and screws, with the goal of eliminating painful movement between those vertebrae. And on paper, this sounds like a reasonable solution to a real and debilitating problem. Chronic back pain is one of the most common complaints I hear from my senior patients. It affects sleep, mobility, quality of life, and independence. I understand completely why so many seniors agree to this surgery when it is offered. But here is what the research actually shows. A landmark study published in the journal Spine followed patients who underwent spinal fusion for degenerative conditions and compared them to patients who received non-surgical treatment, things like physical therapy, targeted exercise, and pain management. After 2 years, there was no statistically significant difference in pain outcomes between the 2 groups. In other words, a significant portion of patients who went through a major surgical procedure with all of its associated risks ended up in the same place as patients who never had surgery at all. For seniors specifically, the risks compound significantly. General anesthesia in patients over 60 carries a well-documented risk of something called postoperative cognitive dysfunction, a condition where patients experience measurable decline in memory, concentration, and cognitive processing in the weeks and months following surgery. Studies suggest this affects between 20 and 40% of seniors who undergo major surgery under general anesthesia. In most cases, it is temporary. But in some patients, particularly those over 75 or those with pre-existing mild cognitive issues, it can become persistent. Spinal fusion also carries significant rates of what surgeons call adjacent segment disease, a condition where the vertebrae above and below the fused segment begin to deteriorate faster because the natural movement and load-bearing of the spine has been permanently altered. Many patients who undergo spinal fusion find themselves back in a surgeon's office within 5 to 7 years, being recommended for additional surgery. My position on this is not that spinal fusion is never appropriate. It is that before any senior agrees to this procedure, they should have truly exhausted, all conservative treatment options. A minimum of 6 months of physical therapy with a therapist experienced in geriatric spinal conditions. Targeted steroid injections, if appropriate. Lifestyle and movement modifications. If all of that has been tried and has genuinely failed, then the surgical conversation can happen. But in my experience, far too many seniors are moving directly from an MRI showing disc degeneration to a surgical recommendation without that critical middle step. Surgery number 2 is total knee replacement. And I want to be careful here because knee replacement is a surgery that, for the right patient in the right circumstances, genuinely does change lives. I have patients who had knee replacements and consider it one of the best decisions they ever made. So I am not here to tell you that knee replacement is never the right choice, but I am here to tell you that the way this surgery is currently being recommended and performed, particularly in patients in their 60s and early 70s, concerns me deeply when I look at the data. Total knee replacement involves removing the damaged cartilage and bone surfaces of the knee joint and replacing them with metal and plastic components. It is a significant surgery that takes approximately 90 minutes to 2 hours and requires general or spinal anesthesia. Recovery typically takes 3 to 6 months of intensive physical therapy. Here is where the complications come in for seniors specifically. Blood clots, specifically deep vein thrombosis and pulmonary embolism, are one of the most serious complications of knee replacement surgery, and the risk increases significantly with age. Infection around the prosthetic joint is another serious concern, and in seniors whose immune systems are less robust, these infections can be extraordinarily difficult to treat and sometimes require a second surgery to remove and replace the entire implant. But perhaps the most underappreciated complication is what happens to the brain. The same post-operative cognitive dysfunction I mentioned with spinal fusion applies here as well. In a 2019 study published in the Journal of Arthroplasty, researchers found that a meaningful percentage of seniors who underwent total knee replacement experienced measurable cognitive decline in the 3 to 6 months following surgery, even patients who had no pre-existing cognitive concerns. There is also the question of whether surgery actually outperforms non-surgical treatment. A study published in the New England Journal of Medicine found that for many patients with knee osteoarthritis, the primary condition for which knee replacement is recommended, a structured program of physical therapy and exercise produced outcomes that were not significantly different from surgical outcomes after 1 to 2 years. My recommendation is this: if you are over 60 and your doctor is recommending knee replacement, ask specifically whether a supervised intensive physical therapy program has been genuinely tried first. Ask about your individual blood clot risk. Ask about infection rates at that specific hospital. And get a second opinion from a surgeon at a different institution before you decide. Surgery number 3 is carotid endarterectomy. This is the surgery that I want to spend the most time on, because it is the one that I think is most frequently recommended without adequate discussion of the risks, and it is the one where patient stories like the one I am about to share are most heartbreaking. Carotid endarterectomy is a procedure to remove plaque buildup from the carotid arteries, the major blood vessels on either side of your neck that supply blood to the brain. When these arteries become narrowed by plaque, the risk of stroke increases. And because the consequences of stroke are so severe, the idea of a surgical procedure to clear that blockage and reduce stroke risk sounds, on the surface, like an obvious and straightforward decision. But the reality is far more complicated, and this is where I need to tell you about a patient of mine named Harold. Harold was 68 years old when I met him. He was retired, still driving, still active in his community. His wife brought him to see me after a routine scan had detected a narrowing in one of his carotid arteries. His vascular surgeon was recommending carotid endarterectomy. Harold had not had a stroke. He had not had a TIA, what people call a mini stroke. He was what we call an asymptomatic patient. The narrowing had been found incidentally on a scan done for a different reason entirely. His surgeon told him the procedure would reduce his stroke risk, which is technically true in some cases. What Harold was not told, at least not in a way that he understood, was that for asymptomatic patients, the absolute risk reduction from this surgery is very small, and that the surgery itself carries a risk of stroke during the procedure of approximately 1 to 3% in even the best surgical hands. For a patient who has never had a stroke and who may never have one, that procedural risk is not a trivial number. Harold had the surgery. During the procedure, a small piece of plaque dislodged and traveled to his brain. He suffered a stroke on the operating table, the very event the surgery was intended to prevent. He survived, but he lost function in his left hand that he never fully recovered. He stopped driving 6 months later. I am not sharing Harold's story to suggest that carotid endarterectomy is never the right choice. For patients who have already had a TIA or a stroke and who have significant carotid narrowing, the evidence for surgery is much stronger. But for asymptomatic patients, and there are many, the decision is far more nuanced than it is often presented. Medical management with statins, blood pressure control, and lifestyle changes has been shown in multiple large trials to produce outcomes comparable to surgery in asymptomatic patients with moderate stenosis. If your doctor recommends this procedure and you have never had a stroke or TIA, please, before you agree, ask them specifically what your absolute risk reduction is. Ask them what their personal surgical stroke rate is, and ask whether optimal medical management alone has been fully considered. Surgery number 4 is elective cardiac stenting in stable patients. Cardiac stenting involves threading a thin tube through a blood vessel in your wrist or groin up to your coronary arteries, the arteries that supply your heart muscle, and placing a small metal mesh tube called a stent to hold open a narrowed section of artery. When performed as an emergency procedure during a heart attack, stenting is life-saving and unambiguously the right intervention. There is no debate about that. But elective stenting performed in patients who have stable coronary artery disease, who are not having a heart attack, who have blockages detected on imaging, is a different matter entirely. And this is where one of the most significant and underreported stories in cardiology over the last decade becomes directly relevant to every senior watching this video. The ischemia trial, a massive, rigorously designed clinical trial involving over 5,000 patients with stable coronary artery disease published in the New England Journal of Medicine, found that elective stenting in stable patients did not reduce the risk of heart attack, did not reduce the risk of death from cardiovascular disease, and did not improve survival compared to optimal medical therapy alone. Optimal medical therapy meaning medications, lifestyle changes, cardiac rehabilitation, and monitoring. For seniors over 60, the risks of the stenting procedure itself include kidney damage from the contrast dye used during the procedure, and seniors are particularly vulnerable to this because kidney function naturally declines with age. There is also a risk of bleeding at the access site, a risk of the stent itself triggering a clot in the weeks following placement, and the requirement to take powerful blood-thinning medications for an extended period after the procedure, medications that increase bleeding risk throughout the body. If your cardiologist is recommending elective stenting and you are not in the middle of a heart attack, I want you to ask one specific question. Has optimal medical therapy, aggressive medication management, cardiac rehabilitation, dietary changes been genuinely tried first? Because the evidence suggests that for stable patients, it should be. And surgery number 5 is elective gallbladder removal in seniors with silent gallstones. Gallstones are extraordinarily common. Studies suggest that between 10 and 15% of adults have gallstones, and that percentage increases significantly with age. The vast majority of people with gallstones, somewhere between 60 and 80%, never experience any symptoms at all. These are called silent gallstones or asymptomatic gallstones. Here is where the problem begins. A senior has an abdominal ultrasound for an unrelated reason. The radiologist reports gallstones. The patient's doctor, appropriately cautious, refers them to a surgeon, and in many cases the surgeon recommends removal of the gallbladder on the basis that the gallstones might eventually cause problems. But the evidence for removing a gallbladder in a senior patient who has never had symptoms is not strong. Guidelines from major gastroenterology and surgical societies generally do not recommend elective cholecystectomy for asymptomatic patients. The reasons are important. The surgery itself, even as a laparoscopic procedure, carries the same general anesthesia risks I have already described in terms of post-operative cognitive dysfunction in seniors. Bile duct injuries, though uncommon, are a serious potential complication. And perhaps most importantly, the risk that a silent gallstone will actually become a problem, will cause cholecystitis or pancreatitis or any acute emergency, is lower than many patients are led to believe, particularly in older patients with other health conditions that may naturally limit their longevity. The calculation changes entirely if symptoms develop. Severe abdominal pain, fever, jaundice, these are signs that the gallbladder is becoming acutely problematic and surgery may become necessary. But for a senior who finds out incidentally that they have gallstones and who feels perfectly fine, watchful waiting with regular monitoring is often the most evidence-based approach, and it is one that every patient should at least discuss fully before agreeing to an operation. Let me bring all of this together. Spinal fusion. Exhaust every conservative option first and understand the cognitive risks of anesthesia before agreeing. Knee replacement. Ask whether intensive supervised physical therapy has been genuinely tried and get your individual blood clot and infection risk assessed carefully. Carotid endarterectomy in asymptomatic patients. Understand your absolute risk numbers, ask about your surgeon's personal stroke rate, and discuss whether optimal medical management is a reasonable alternative. Elective cardiac stenting in stable disease. The ischemia trial evidence is clear. Medical therapy first. Stenting is for emergencies and for cases where medical therapy has genuinely failed. Elective gallbladder removal for silent gallstones. Watchful waiting is supported by evidence. Symptoms should drive the surgical decision, not an incidental finding on a scan. I want to end with this. The most important thing I can tell any of my senior patients, and any of you watching this video, is that you have the right to ask questions. You have the right to a second opinion. You have the right to say, I need more time to think about this. A good surgeon will never pressure you into a decision. A good surgeon will welcome your questions because an informed patient is always a better surgical candidate than one who did not fully understand what they were agreeing to. Your age does not diminish that right. It actually makes exercising it more important than ever. Please leave a comment below and tell me, has anyone in your life been through one of these 5 surgeries? What was your experience? I read every single comment and I respond to as many as I can. If this video was helpful, share it with someone you love who is over 60. It might be the most important thing you do for them today. And subscribe to this channel if you want to keep receiving honest, evidence-based information about senior health, without the hype, without the fear-mongering, just the truth that every person over 60 deserves to have. I am Dr. Michael Kent. Thank you for watching. Take care of yourself and the people you love. I will see you in the next one.